what is common amongst these four pictures that you are seeing? That they all had chronic liver disease or cirrhosis. So you see Meena Kumari, the legendary Bollywood actress, known for her performance in the great Bollywood movie Pakiza. Then you have Beethoven, one of the greatest music composers. Then you have Bobby Moore, the greatest defenders, arguably, in soccer, and he led the British team to World Cup victory in 1966. They've all expired because of cirrhosis or liver disease. And then you have Amitabh Bachchan, who has chronic active hepatitis and who is one of the great Bollywood actors and still with us. So liver disease has affected many a great people and continues to do so. Around 50% of all liver disease is related to alcohol. Now, it's very important to know the normal values of liver function tests. And all these that you see are classic liver function tests, while these are not normally included in liver function tests. So bilirubin we shall discuss as we go on. It has three components: conjugated, unconjugated, and delta bilirubin. SGPT, or also known as ALT, and SGOT, also known as AST, also known as transaminases. So these are actually released from the hepatocytes when there is hepatocyte injury or inflammation, and they spill over into the bloodstream. They are found in hepatocytes, and any disease affecting the hepatocytes will lead to an increase in SGPT and SGOT. SGPT is classically found mainly in liver disease, while SGOT has many sources. SGOT can be found in the muscles, in the liver, and other organs. So, if there's a disproportionate rise in SGOT, then one must think of these sources also. And it's important to realize that the normal values for all these lab tests in the LFT may vary from one lab to another to some extent, and even the units can be different, but this is the standard unit and this is the standard value. Levels of SGOT-PT less than 300 are non-specific. However, if they're going more than 500, they indicate hepatitis. Now coming to alkaline phosphatase. So where does alkaline phosphatase come from? So alkaline phosphatase is found in the cells which line the biliary ducts and biliary ductules. So it is mainly found in these cells, and not classically too much is there in hepatocytes. Only the hepatocytes which line the biliary canaliculae, you get some alkaline phosphatase, and that too in the epithelium. So diseases which cause hepatitis classically, that is inflammation or damage to hepatocytes, do not really lead to much of an increase in alkaline phosphatase. However, if there's obstruction in the biliary tract, then alkaline phosphatase increases, because like I told you, it is related to the cells which are lining the biliary system. Now, it does not increase because there's a regurgitation. It increases because there's a stagnation of biliary flow. Bile is not being excreted into the intestine from the liver, and the metabolism of these cells alter, and there's an increased synthesis of alkaline phosphatase, and the alkaline phosphatase enters the bloodstream. Alkaline phosphatase so classically elevates in obstruction to either the extrahepatic biliary system or the intrahepatic biliary system. So what is called obstructive diseases or cholestasis. Alkaline phosphatase minor increases are not specific. Again, anything less than 3 times upper limit of normal, that would be around 350, is non-specific, but it is touching more than 500, it becomes very specific and suggestive of biliary obstruction. The other conditions in which you may get alkaline phosphatase high is SOLs in the liver, such as metastasis, or if there's infiltration by granulomas, that is small granulomas infiltrate the liver, such as in biliary tuberculosis. Cancer is very important. If you get isolated rise in alkaline phosphatase, always think of cancer also. Then albumin, you have some idea about albumin, we shall discuss it. Globulins are not important to the intensivist. And GGTP is an enzyme which is done when alkaline phosphatase is increased. And if GGTP is normal, that means alkaline phosphatase is coming from another source. Alkaline phosphatase, apart from the liver, also comes from the bone, the intestine, malignancies, and placenta. And here, if the GGTP is normal, it becomes imperative to look for the source of alkaline phosphatase. The other test which is done to confirm the hepatic origin of alkaline phosphatase is 5-nucleotidase. Unlike GGTP, this is very specific. If it is increased along with alkaline phosphatase, it means liver is the source of alkaline phosphatase. And if you want to see the source of alkaline phosphatase, like if you are thinking it's not hepatic, then you have to do fractionation of alkaline phosphatase, which tells you what is the source, whether it is the bone or the placenta or the malignant cells which are releasing alkaline phosphatase into bloodstream. Then moving on to prothrombin time and INR. So prothrombin time normal is control plus minus 1 second. Similarly, INR is 1 plus minus 0.1. Then another test is ammonia, and these are normal values. So this is, in a nutshell, the liver function tests that are standard and those that we have to deal with and we have to understand. We shall elaborate upon this as we go on. So coming to the metabolism of bilirubin and the causes of increased bilirubin, which characteristically causes jaundice. So bilirubin comes from RBCs. And when there's a breakdown of RBCs in the reticuloendothelial system in macrophages, you get the formation of unconjugated bilirubin, which enters the bloodstream. And when it enters the bloodstream, it goes to the hepatocytes, with its uptake and conjugation. Conjugation occurs because it has to be secreted into bile. So conjugated bilirubin is secreted into bile and thereby goes into the feces. Part of it undergoes enterohepatic circulation in the form of bile salts. So when there is excessive destruction of RBCs, as in hemolytic anemias, your unconjugated bilirubin levels go up because the overall turnover of the unconjugated bilirubin increases. However, there's a limit to the level of unconjugated bilirubin that you can get. The upper limit in hemolytic anemias is approximately 5 milligram per deciliter, because the turnover cannot be more than that. The other cause is reabsorption of blood or hematomas, and sometimes drugs can cause hemolysis or and other causes of hemolytic anemias. Condition important is Gilbert syndrome, which is associated with an impaired uptake, and this is a genetic disorder seen in 5% of the population, and you may get isolated unconjugated bilirubin up to 5 milligram per deciliter in these patients. Unconjugated bilirubin is not bound to albumin, so it is bound to albumin, and thereby it is not excreted into the urine, and thereby does not cause high colored urine. Unlike conjugated bilirubin is not bound to albumin, and because it is not bound to albumin, it is able to filter across the glomeruli and get excreted in the urine. Thereby, conjugated bilirubin is the bilirubin which causes high colored or deep yellow urine. There are multiple causes of elevated conjugated bilirubin, which is the classic jaundice, and all kinds of liver disease can cause an elevation in conjugated bilirubin. Conjugated bilirubin rises because there is damage to the hepatocytes, or there is a problem with the secretion, that is, there is an obstruction in the biliary tract. So in all these conditions, your bilirubin levels will go up. If there's an obstruction in the biliary system, alkaline phosphatase will be high. If there is a hepatocyte damage, that is classic hepatitis, then your SGPT will mainly be high. So these are, the conditions which are associated with jaundice in a nutshell, and bilirubin metabolism. Now, what is delta bilirubin? So when conjugated bilirubin is circulating in the blood for a long time and there are high levels, you get albumin binding to conjugated bilirubin as well, and this does not get excreted. So that is called delta bilirubin. Other thing to realize is that conjugated bilirubin levels do not really go beyond around 20 to 25 milligram per deciliter unless there is a problem in renal excretion of bilirubin or there is concomitant hemolysis going on. And the other thing is that what is the level of indirect bilirubin in unconjugated hyperbilirubinemia. So the level of indirect bilirubin has to be more than 85%. It is not more than 50%. If it is something like 60% unconjugated bilirubin and 40% conjugated bilirubin, that is still direct bilirubin jaundice. That is not unconjugated hyperbilirubinemia. So that has to be realized. More than 85% of indirect fraction has to be there to say that this is predominantly unconjugated hyperbilirubinemia. Now moving on to albumin. So albumin, you have some idea because we deal with albumin all the time in critical illness. So the normal values are more than 3.5, but 5% of healthy young adults in one survey had albumin less than 3 grams. So 3 grams can be seen normally also sometimes, but 3 grams is the cutoff for low albumin. And it is decreased in advanced CLD, but patients who present acutely with acute hepatitis or acute liver failure will not have a decreased albumin. However, if you stay in the ICU for some time with critical illness, your albumin levels go down. So there are multiple reasons. There is increased catabolism, there is increased volume of distribution, there are GI losses, there can be renal losses. So multiple reasons can lead to decreased albumin in critical illness as well as in chronic diseases. In chronic diseases of the kidney, you can lose albumin. If there's malabsorption, protein absorption is decreased, so albumin can be low. If there's a nutrition deficiency, then again albumin can be low. So multiple reasons can lead to low albumin. Now, it's important to realize that even if there is no critical illness, if the patient comes with a normal liver but acute disease, then albumin will fall after around 10-12 days because the half-life of albumin is 21 days. So albumin becomes very important in distinguishing chronic liver disease from acute liver disease. Now, moving on to prothrombin time and INR. So we all know that prothrombin time increases in chronic liver disease. However, in early chronic liver disease, it may be normal. And we all know that increases in DIC. So most of the time. So these two conditions we are well aware of. And it also increases in acute liver failure. Acute liver failure cannot be diagnosed without an elevated prothrombin time. It has to be greater than 1.5 times. So what are the other causes? So the other causes are the patient is on vitamin K antagonists such as warfarin. The newer anticoagulants do not really alter prothrombin time. They may or may not. And then there's malabsorption because vitamin K has to be absorbed to form the procoagulant factors involved in prothrombin time. And then antibiotics because antibiotics alter the flora of the gut, and vitamin K comes not only from the diet, it also comes from synthesis in the gut. And some of the antibiotics, especially the cephalosporins, may alter the formation of procoagulant factors also. Now coming to ammonia. So ammonia is not a classic liver test. We all know that, but ammonia is done sometimes, especially in acute liver failure. So arterial versus venous. We all know that arterial is much more reliable than venous. So whenever you want to do ammonia, do arterial ammonia. And arterial ammonia is done because it correlates better with the degree of hepatic encephalopathy and prognosis in ALF, and it is much more consistent. So what is the metabolism of ammonia? So what happens is ammonia is mainly produced in the gut. From the gut, it is carried by the veins into the liver. From the liver, it goes to the IVC and the right atrium. However, in chronic liver disease, what happens is there is collateral formation, and these are the communications between the venous system and the GI tract, what are called varices, and they are carried directly to the IVC and into the heart. Ammonia is carried directly. When ammonia goes from the gut to the liver, lot of it is converted into urea, and the remaining goes to the heart as shown. Now, all this is pumped out, and when this is pumped out, that is the arterial ammonia, part of it is taken up by the muscles. This is very important, and it's converted into glutamine. And some of it is also taken up by the kidneys and converted into glutamine and other substances and excreted. So this is the flow of ammonia in the arterial system, and then it goes to the veins and is carried back by the IVC into the heart. So, this is little variable, the uptake in the muscles and the kidneys, and so many other factors. That is why venous ammonia is inconsistent, and the arterial ammonia is much more reliable. That is why we do arterial ammonia. So as far as the points for ammonia are concerned, arterial ammonia is more accurate. In 10% of chronic hepatic encephalopathy, ammonia can be normal. In chronic hepatic encephalopathy, it does not correlate well with the clinical condition. In ACLF, always elevated, and serial values are not helpful. ALF always elevated, and serial values correlate with prognosis. And ammonia is removed by dialysis. So this is in a nutshell about ammonia, and this is all that you really have to know about ammonia. It's very important in acute liver failure, where it directly correlates with prognosis, and that has to be known. Then moving on to jaundice in the ICU, patient comes with another disease. There's no liver disease, he develops jaundice. So what are the common etiologies? One is ischemic hepatitis or development of right heart failure. Then nosocomial sepsis, blood transfusions. These are the commonest causes we shall discuss. Blood transfusions because they lead to some degree of hemolysis. Jaundice may appear immediately if there is a lot of hemolysis, or they can be delayed hemolysis. Then post-operative jaundice. Why do you get in post-operative jaundice? Because they can be intra of hypotension, they can be use of halothane or other fluorines which can cause hepatotoxicity, because post-operative jaundice is like SIRS, and there can be hepatic dysfunction. So all these multiple factors can lead to post-operative jaundice. Then there can be resorption of blood, DIC, because DIC causes hemolytic anemia. Again, all kinds of hemolysis, positive pressure ventilation because there is ischemia induced by, being on the ventilator. When you're on the ventilator, the right heart return is decreased. There increased pressure in the hepatic vein, and there is relative ischemia transmitted backward as well as forward because the cardiac output decreases. So there is some degree of ischemia. Total parenteral nutrition after 2-3 weeks can cause jaundice and altered LFT. This is because the total parenteral nutrition leads to a stagnation of biliary flow. There's a stagnation of biliary flow as the gut is not being used for feeding, and this leads to jaundice, as well as there is hepatic steatosis. That is, there is fat deposition in the hepatocytes leading to hepatocyte dysfunction, and this is related to some degree insulin resistance and also the components of TPN. How do you treat TPN? So when the patient is TPN, try to stop TPN. Obviously, if you cannot, then mix it up with the enteral. Some enteral has to go, and this usually resolves. But one has to realize that the jaundice and altered LFT is occurring because of TPN. Multiple drugs can cause jaundice in the ICU. We shall discuss this. Now, coming to the interpretation of raised SGPT, SGOT, and alkaline phosphatase. Sorry, that is supposed to be SGPT, SGOT. Now, when you see a patient who has altered LFT and you want to make sense of it, it is very important to realize that we have to classify this into a hepatitis picture or a obstructive picture. So in hepatitis picture, the SGPT and SGOT will be more than 500, and alkaline phosphatase will be less than 3 times upper limit of normal. So what happens is that there is a hepatitis, there is inflammation of the hepatocytes, there is damage to the hepatocytes. So the SGPT and SGOT get released from the hepatocytes into the bloodstream. But alkaline phosphatase, like I told you initially, comes from the cells lining the biliary tract and is not much affected. So this is classic hepatitis, the causes of which we'll discuss, and the overall levels of SGOT-PT do not directly correlate with the hepatic injury severity. Bilirubin and INR are much more important for assessing the severity. Now, if there is obstruction in the biliary tract, what is called an obstructive pattern or a cholestatic pattern, then SGOT-PT does not rise much, less than 300, and alkaline phosphatase will be more than 4 times upper limit of normal. If your LFT pattern does not conform to any of this, that is, it is like this, then it is a mixed pattern. And a mixed pattern is also generally consistent with a hepatitis, and sometimes it can be obstructive also. So this is, your overall approach to classifying the LFT and getting a pattern out of it, and then trying to proceed as to what is the etiology. So this is a mnemonic for hepatitis. Getting a hepatitis kind of a picture, then you have this mnemonic liver flaps, try to get to the etiology once you classify it as a hepatitis. So lethal is malignancies, infections, all kinds of infections, including sepsis, vascular causes like Budd-Chiari or ischemic hepatitis, ethanol, Ray's syndrome in children, flavotoxins or all kinds of toxins, including supplements. Lower means acute choledocholitis or acute biliary tract obstruction, which is a cause outside the liver, but it can lead to marked elevation of SGOT-PT sometimes. And autoimmune hepatitis, pregnancy-related disorders, and syndromes such as Wilson. So you remember this mnemonic, and you can get to the etiology. Now coming to the specific conditions which are common in the ICU, what happens to the LFT in viral hepatitis? In viral hepatitis, what you get is an SGOT-PT more than 500, and there will be some jaundice, and jaundice is generally present but sometimes may not be there. It is called anicteric hepatitis in those conditions. And the viruses common are A, B, and E, and rarely sometimes viruses like cytomegalovirus, herpes simplex, and such viruses dengue virus, they can all cause viral hepatitis. Viral hepatitis can lead to liver failure also. So one has to see the INR, the ammonia, and the sensorium. The septic hepatitis is due to biliary obstruction. The cytokines lead to biliary obstruction, a stagnation of biliary flow, what is called cholestasis, and characteristically you will get alkaline phosphatase high, direct bilirubin high, but sometimes only SGOT-PT may be high because the cytokines damage the hepatocytes, and sometimes everything may be increased. So septic hepatitis is classically because of biliary obstruction. And the other reason is the dramatic fall in blood pressure can cause ischemic hepatitis, which can lead to acute liver failure also. Septic hepatitis, the bilirubin can go up to around 20-25, but not more than that. But this is not common, and it does not lead to acute liver failure. Coming to drug-induced, so drug-induced is not that common, but one has to recognize it. And you can have a hepatitis picture or obstructive picture, which is less common, or a mixed kind of a picture in LFTs, like I showed you. The drugs which are common are anti-epileptics, psychiatric drugs, certain antibiotics like cotrimoxazole, augmentin, clavulanic acid, amoxicillin, clavulanic acid, or even drugs like macrolides. So many drugs can cause drug-induced hepatitis. Ischemic hepatitis occurs in the setting of sudden drop in blood pressure, and there's hypoxia to the hepatocytes and the hepatocyte destruction, leading to release of HODPT in large numbers. They are generally more than 20 times upper limit of normal, going beyond 700, 800, and they fall also rapidly if you resolve the fall in blood pressure. Bilirubin rise is slower after SGOT-PT, and ischemic hepatitis can lead to acute liver failure. Then coming to tropical infections like malaria, rickettsiosis, scrub typhus, leptospirosis, here is very important to realize that tropical infections can cause all kinds of LFT. There is no specific LFT, and generally you get a mixed LFT pattern. But leptospirosis is one condition which is very important in terms of LFT. In this, your bilirubin is high and your alkaline phosphatase will be very high, while HODPTB will be normal or nearly normal, minimal rise. Mainly alkaline phosphatase rises along with bilirubin in leptospirosis. The liver is always involved in severe leptospirosis. Very important to realize that. Then moving on to alcoholic hepatitis. In alcoholic hepatitis, which is very common, the patient may or may not have underlying cirrhosis. He comes and there may or may not be recent history of alcohol intake, but he is a drinker. and your SGOT is always higher than SGPT by more than 2 times. That is very important in 90% of the patients. And the SGOT does not go more than 300 or 400 maximum. And alcoholic hepatitis persists for a few weeks. It can have a concomitant fever, which can last for a few weeks. There can be renal failure because of a release of cytokines, because alcoholic hepatitis is a surge physiology. So one must realize alcoholic hepatitis, and if it occurs in the setting of cirrhosis or chronic liver disease, then you'll get acute or chronic liver failure. Now we shall move to some cases. I'll show you 3 cases, and these are characteristic LFTs. This is the first patient, and this patient, this is the history. Patient has developed jaundice and altered sensorium of 1 day on ATT, and this is the LFT. So here you can see there is some elevation of bilirubin, but the SGOT-PT is more than 1000. That's very important. And there's a normal alkaline phosphatase by and large. Albumin is normal, PTNR is increased, ammonia is increased. So important to realize is the marked elevation in SGOT-PT and near normal alkaline phosphatase, which is a hepatitis picture. And it's important again to realize that if your SGOT-PT is more than 1000, then there are only 3 causes which cause it to be high in 95% of the patients. One is drugs, second is viral, and third is ischemia. So if you're getting SGOT-PT more than 1000, always look for a virus etiology or ischemia, your blood pressure, or look at the drugs. These are the 3 causes which cause 95% of SGOT-PT more than 1000. So it's very simple. 5% are rare causes which fall into the purview of hepatologists. You don't really have to bother about it. And we are now here looking at drugs. So we have ATT. ATT is known to cause hepatitis. So this is ATT-induced hepatitis. Now, at the same time, if you look at albumin is normal. So obviously this is acute insult. So albumin is normal. INR has gone up to 2.5 and the patient has altered sensorium. So this is what is called acute liver failure. This is classic LFT of acute liver failure. Now moving on to the second LFT and the second patient. So this patient develops acute symptoms again with fever, diarrhea, pain, abdomen, oliguria, and this is the LFT. Now if you look at the LFT, the SGPT and JSGOT are around 500. Alphos is just 2 times upper limit of normal. Albumin is decreased. Very important to realize albumin is decreased and INR is increased and ammonia is also increased and urea creatinine is also increased. So if you look at just SGOT, PT and alkaline phosphatase and what I told you, this is again a hepatitis. This is a hepatitis picture. Now when you get acute hepatitis, acute because the patient has acute symptoms, one also has to rule out chronic liver disease, whether the patient was harboring a silent chronic liver disease, and this is an acute on chronic liver disease kind of a pattern. So there one has to take help of albumin and INR. So if we look at the albumin, albumin is decreased, right? So that's a pointer towards chronic liver disease. And again, INR is increased, which can again be a pointer towards chronic liver disease. So you look at the ultrasound, because ultrasound is very helpful in diagnosing chronic liver disease. There's ascites, splenomegaly, portal collaterals, and a nodular liver. So this means that the patient has chronic liver disease or cirrhosis, and on top of that, there are acute symptoms. So this actually becomes acute on chronic liver failure. So this is how you go about interpreting the LFT in such patients. Now coming to the third patient, this is a non-alcoholic CLD, and he presents with upper GI bleed. And the vitals are stable, but the blood pressure is relatively low for an elderly man. And if you look at the SGPT, it's around 300 only. And alphos is normal, albumin is markedly low, INR is somewhat increased, ammonia is normal. So this is consistent with chronic liver disease. In chronic liver disease, when we get patients in the ICU, they come for related complications such as upper GI bleed or SBP or AKI or hepatorenal syndrome. So in these patients, this is the LFT you will get. In chronic liver disease, SGOT-PT remain less than 300, alkaline phosphatase will be normal or just slightly increased. Albumin will generally be low, less than 3, and RR will be increased normally. And ammonia is generally normal unless the patient is in hepatic encephalopathy, and your bilirubin may be normal or slightly increased. It does not increase markedly. However, if the complication which has brought the patient of chronic liver disease to the ICU affects the liver, then your LFT will get altered and become more severely deranged. For example, if the blood pressure drops less than 90, then you'll get ischemic hepatitis also on top of chronic liver disease. And what you'll get is acute chronic liver failure. Your SGOTPT will rise markedly, bilirubin will rise. Or if the patient goes into sepsis because of SBP or some other infection, then again you will get acute and chronic liver failure and LFT will worsen. So these are the three classic subsets of liver disease and LFT patterns we get: acute liver failure, acute and chronic liver failure, and chronic liver disease with complications. Moving on to the last case, this is a patient pneumonia and mild ARDS AKI treated with high flow and azithromycin. Initial LFTs are normal, but before discharge, this is the LFT we get. So if you look at the LFT, there is a very slight elevation in bilirubin and there is a marked elevation in alkaline phosphatase. Right, alkaline phosphatase is more than 500, SGOTPT is by and large normal, albumin is decreased, INR is mildly increased. So what does this have, this patient? So this patient has a cholestatic picture or an obstructive picture. This patient has a cholestatic or an obstructive picture. And what is the cause? So the cause here is you have to look at the drugs, and azithromycin is a macrolide, and macrolides are known to cause cholestatic kind of picture and elevation in alkaline phosphatase. So that is what is happening here, because the initial LFTs were normal. If the patient goes into sepsis and there is an elevation of alkaline phosphatase initially, then it is because of sepsis, but the LFTs initially were normal. It's only at discharge that you're finding a rise in alkaline phosphatase, and that is here because of azithromycin. So if you stop azithromycin, this will subside. So I had a patient once with azithromycin, and azithromycin went on for 2-3 weeks for some reason, and the alphos actually went on to 1500, but the patient remained normal. And if you look at albumin, why is albumin low? So he's been in the ICU with critical illness, so albumin has decreased. And why the INR is increased? So again, because of criticality being in the ICU, there can be some elevation in INR. So this was about these patients, and these were the classic LFTs. And if there are any confusions, please let me know in the chat box, put up your questions. So last couple of slides, radiology. So coarse ecotexture is not cirrhosis. It is often reported the patient has a coarse ecotexture in the liver. Coarse ecotexture is not cirrhosis. It is because of infiltration into the liver, mostly by fat or sometimes by other things also. The other thing is, what kind of a liver do you get in ALF? ALF has a classically shrunken liver because the hepatocytes get damaged. And sometimes you may get a enlarged liver. That is because of venous congestion, such as in Budd-Chiari or other vascular conditions. And in obstructive kind of patterns, that is cholestatic patterns, you have to do MRCP because there is obstruction in the biliary tract or the outside the liver or within the liver. So this is the LFTs that I wanted to talk about and highlight for you as intensivists, an approach to LFT, what kind of a pattern you are getting, and then try to find out the etiology. And of course, the management is supportive and specific in some conditions, depends on what you're dealing with, and it goes into the purview of the gastroenterologist and hepatologist, but this is something you should know what I've told you. And these are the takeaway points. Patients should be classified into acute and chronic liver disease. Second point, acute hepatitis, viral drugs, alcohol are commonest etiologies. Third point, 95% of SGOTPT greater than 1000 is viral, ischemic hepatitis or drugs. Fourth point, LFT pattern must be recognized, whether it's a hepatitis pattern, obstructive pattern, or a mixed pattern. And fifth point, very important, sometimes CLD patients may present with hepatic encephalopathy and normal LFT. And you will realize this hepatic encephalopathy only if you do the ammonia levels. Sometimes this also happens, and I've seen this. So ammonia is very important at times. So friends, that's about it. And let me know if you have any questions, comments, etc. I'll be happy to answer them. Thank you so much.